We'll move on to the next topic. It's recurrent pain after surgery in chronic pancreatitis. What to do next? I invite Dr. M Ibrarullah for the presentation. It's over to you, sir.
Good morning, everybody. Recurrent pain after surgery in chronic pancreatitis. I know this is a difficult question to answer, or maybe I can say the question is easy, but the answer is difficult. The overall incidence of pain relief following surgery in chronic pancreatitis is to the tune of 75 to 90%. This is the immediate result, which drops down to about 50 to 60% over a period of 5 to 10 years. That means 1 in every 3 patients, or roughly 1/3 of the patients who had initial relief would present with recurrence of pain or relapse of pain in course of time. The predictors of good results as per some of the studies published are inflammatory mass in the pancreatic head, alcohol-induced pancreatitis, or a presence of a dilated main pancreatic duct. And this might sound a little paradoxical, but histologically severe calcification or those with severe fibrosis may have good result after surgery. This may be an indication that possibly this patient is having a pancreas that is dying out, or what is called the burnt out pancreas. That is why the result is good. And the predictors of poor results are symptoms present for more than 3 years, patients who are already on opioid analgesics before surgery, more than 5 endoscopic interventions prior to surgery, or continuous pattern of pain, or those with high SBK pain score, and those who had post-operative complications are likely to have poor results after surgery. But then the most recent publication on this is a multi-center trial published in British Journal of Surgery. That would basically sorry, it's not showing. Anyway, basically what they have identified are only these 2 factors, that is symptoms present for more than 3 years, and patients who are on opioids would have recurrence of pain, or are the poor, these are the poor predictors of surgical outcome. So the basic reason for a recurrence of pain after surgery is a mistaken diagnosis or a misdiagnosis, which could be extrapancreatic or pancreatic in origin, and both resulting in inappropriate surgery or inadequate surgery. Looking at the extrapancreatic causes, see for example, this particular patient has gallstone as well as the CBD is dilated, in addition to this appearance of a dilated duct with pancreatic duct with stones. So obviously in this patient would require management of all the 3 components of pathology seen in this imaging. That means the gallstone has to be treated, the CBD dilatation has to be treated, as well as you're doing a drainage for the chronic pancreatitis. That obviously is the main surgery. Additionally, there could be acute acid peptic disease, which can be the cause of recurrence of pain. It's not a pancreatic pain, it's a non-pancreatic cause of pain. Or it could be vascular compromise in the form of chronic mesenteric ischemia or a celiac artery stenosis, which exactly mimic the pancreatic pain, but the cause is somewhere else. Next, the inadequate or incomplete surgery. For example, this particular patient has a dilated PD along with a pseudocyst, and here also you can see a dilated PD, intrapancreatic pseudocyst. So your surgery has to address all these problems seen in this imaging. That means you have to do a wide laying open of the duct along with the drainage of this intrapancreatic cyst, which is seen in this. Anything short of that may be a cause for surgical failure. And look at this patient and look at the bulk of stones in the pancreatic head as well as in the distal pancreas. So this particular patient needs a wide and a thorough phrase procedure along with the wide drainage of the duct, removing all these distal stones. So anything short of that is obviously could be a cause for a surgical failure. Now look at this patient. He has stone in the pancreatic head, but what he has is a biliary obstruction as well as a pancreatic ductal obstruction, grossly dilated biliopancreatic duct. But simple drainage of these 2 systems may not suffice here, because the cause of obstruction is a superimposed malignancy. So anything short of resection is not going to relieve this problem. This has already been talked about in length by Dr. Surendran. However, just to highlight this particular point, that missed malignancy is an important cause of failure of surgery in chronic pancreatitis. There are several published literature from India as well as from abroad on this topic. So as I say, malignancy is a necessary evil accompanying chronic pancreatitis across all spectrums of the disease. The overall incidence is 4 to 12%, with the highest reported incidence with hereditary pancreatitis to the tune of 20%. Of course, fortunately, we don't see much of this hereditary pancreatitis. Maybe in my 30 years of career, I might have seen just one, and that was just last month I came across a patient where the entire family had chronic pancreatitis, including 1-year-old child. And the incidence is higher with calcific pancreatitis as compared to alcoholic pancreatitis. And this is one report that suggests that the phrase specimen, what was supposed to be only chronic pancreatitis, the malignancy was found in this extracted tissue in about 1 to 6%. Superimposed malignancy, like this has already been spoken about. And the incidence of malignancy in the pancreatic head mass could be to the tune of 18 to 40%. And this is what I think everyone is talking about. These factors identified are the predictors of malignancy in the pancreatic head mass. That's old age, recent worsening of abdominal pain, gastric outlet obstruction, recent significant weight loss, raised serum bilirubin, CA99, and a grossly dilated MPD and CBD was found to be associated with malignancy. Yeah, this is one entity I think the chairperson was trying to ask. This particular entity has been recognized in the last 3 decades, and this has emerged as a very important mimic of chronic pancreatitis. Just look at this picture. This has been taken from one of these publications. The first impression to an untrained mind would be that this is possibly a case of chronic pancreatitis. But indeed, this was a case of IPM and not chronic pancreatitis. So much so that approximately 12% of patients with IPMN had a clinical diagnosis, or you can say misdiagnosis of chronic pancreatitis. But then there may be some common association between the two, because there is 2% of all cases of chronic pancreatitis had concomitant IPMN. This is again a case of IPMN which very closely mimics chronic pancreatitis. So some of the factors or the indicators of IPMN are the higher incidence in female patients, old age, less consumption of alcohol, smoking in IPMN. So answering this question, how to manage this recurrence of pain after surgery in chronic pancreatitis, is first and foremost review history. If you think this is a non-pancreatic pain, then these basic investigations are in order, like ultrasound, endoscopy, or maybe in cases of, if you're thinking of mesenteric ischemia, you may have to do a angio-CT to confirm that. On the other hand, if you think this is a pancreatic pain, review the CT scan which the patient already had before surgery, and also repeat a CT scan, compare both the things. See if there was already an existing pancreatic head mass, or there is a head mass at present, or it was a head dominant disease. If that be so, then you need to exclude malignancy by at least doing this basic test, CA99, CA, or a US guided biopsy. And if the malignancy has been ruled out by this basic test, then you have to answer whether this head has been adequately treated. And for those with dilated main pancreatic duct with calcification, compare it with the previous CT. Just make sure that whether the drainage which has already been done was adequate or not, or if there is again recurrence of stone and that needs to be drained. On the other hand, look for the misdiagnosis or concomitant CA in these patients with a head dominant disease, or look for it in the previous CT scan if it was there, or if it is there in the present CT scan. And again, look for this mistaken diagnosis of IPMN. These are the indicators: grossly or focally dilated pancreatic duct, old age, female, no or less alcoholic consumption or smoking. Then of course, if you're suspecting IPMN, you need to confirm it with tumor markers, imaging, and US guided cytology. So what are the treatment options then? One, like if it's a dilated duct with recurrence of stones or the residual stones, you may have to do a revision drainage procedure. That would mean a wide head coring with wide drainage of the ducts. Or if it is a head dominant disease or a head mass, you may have to consider duodenal preserving head resection. or a distal pancreatectomy, depending on where the disease load is. And if you're suspecting malignancy, obviously the next course of action is a resection in the form of a Whipple's pancreatic duodenectomy or a total pancreatic duodenectomy. But then with all these measures, whatever you may do, 10% of the patient will still continue to have pain. So here comes this neurogenic origin of this pain, or this neural sensitization of pain, where the patient needs a neuropsychiatric evaluation. Then several modalities have been recommended to treat this neuropsychiatric component of the pain. This was discussed in the other hall yesterday. I was privy to that. Of course, that's a lot of it is there, but they are more of experimental basis, on the trial basis, but nothing for sure, which can give you permanent relief or the definite relief to this kind of pain. You need to continue medications in these patients, analgesics in various forms, or US-guided cilia ganglion block is an option that you may have to consider, even though this gives a temporary relief, but there are patients who would certainly benefit with this kind of approach. Then, of course, last but not the least is total pancreatectomy. When everything fails, you have no option, you may have to consider total pancreatectomy, but that is then at the cost of severe nutritional impairment. So you need to balance out and then take a decision. Total pancreatectomy, or alternate is additionally islet cell autotransplantation. So this is about the pancreatectomy and islet cell transplantation. The overall outcome is about 80% pain relief, and approximately 30 to 50% do not require insulin. That's the benefit of islet cell transplantation. There's improved quality of life, and of course the results are much better in pediatric group of patients. These are some of the current, some of the emerging trends that may like to add. Of course, the gene therapy, but this is more to control the disease progression rather than to treat the pancreatic pain. Chemical pancreatectomy has been tried in animal models where acetic acid is injected into the pancreatic duct, which causes a total destruction of the exocrine pancreas, what is called chemical pancreatectomy, but the islet cells are preserved. But this is again on experimental basis, yet to be implemented in yet to have a human trial. So just to take home message, what you do when you have a recurrence of pain after surgery, that review the diagnosis, look for mistaken or a misdiagnosis, then revision surgery in the form of drainage or resection as the case may be. Then total pancreatectomy and islet cell transplantation could be the modality as the last resort. Thank you.
Thank you so much, sir. Any questions?